Everybody, welcome to this episode of The Compliance Guy. I'm Sean Weiss, and as always, I want to begin by saying thank you all so much for tuning in, logging on, and just hanging out with me and my special guest for a little while as we get to talk about all things healthcare. Today, I'm joined by one of my favorite people, Jordan Johnson of Oncospark. As many of you know, Jordan and I get an opportunity to do another podcast with a third member, Eric Rubenstein. For those of you that are not hooked on that show yet, it's called Coffee Compliance and Chuckleheads Coffee After Dark. It's a program that we do twice a month, usually after 5 o'clock in the evening, hence the term Compliance After Dark. And yes, it is good to the very last drop. I hope I don't get sued for copyright infringement or something like that. Wasn't that an old Maxwell House saying?
That's
Jordan?
right. That's it. Maxwell House, baby. Good till the very last drop.
That's it. That's it. So, I spend so much time on my podcast, obviously, talking about regulatory compliance, health law, the intersection to business of medicine. But I don't think a lot of folks realize that, my real background before I became AKA the compliance guy, I was a hospital administrator. I was a practice administrator, and I really cut my teeth after I, learned coding and billing and documentation. I really cut my teeth in operations and practice management services. And as I've continued to watch what's transpired in our industry, sure, I've been looking at it now for the last, 2+ decades, almost 3 decades, but really over the last decade. And I think we'll start there because I think, the system's been broken for a long time, even prior to Barack Obama becoming president. But I think ACA, the Affordable Care Act, is something that really began the downward spiral in so many senses for the healthcare industry. And I think people were just so enamored with, Barack Obama, as I was. I voted for the guy the first time. And there was such a desire to get healthcare reform in place that people said, look, let's just pass it and then we'll read it. And that's exactly what happened. There was so much pork barreling in that. There was so much garbage in it. And there were so many lies that were told to the American people, like, you'll get to keep your primary care physician. No, you didn't. People's jobs were lost. The advent or the major push into electronic medical records, which in a 2017 interview with Barack Obama, he said, one of my biggest regrets about pushing healthcare in the direction that I did was forcing people onto electronic health records because it was such a slow trudge. And I didn't realize how far behind technology-wise the medical field was and how unwilling or incapable, or whatever term you want to use, providers were to adopt these electronic health records. But the fact is, and I think he finally admitted to it, EMRs coming into the healthcare arena forever changed the physician-patient relationship. It was no longer about being face-to-face and communicating and understanding what was going on with the patient. It was now, I'm sitting with my back to the patient and I'm typing on a keyboard. And I'm more concerned about point and click than I am with really understanding, why is my patient here today? And there's a lot of other reasons that are tied into it about insurance regulations and the games that they play for requiring this number of elements of an HPI or ROS or PFSH or examination, and how do you calculate medical decision making, and then nobody really understanding what does medical necessity mean until we got court decisions, right? The Kaminsky case in the Second Circuit Court of Appeals, and some of the other big cases, right? That people were finally able to start to level the playing field, but it's now imbalanced again. And I want to talk with you, Jordan, because you're really on the front lines. You're on the cutting edge of technology, and you're really a disruptor. And I don't ever compliment you on Chuckleheads because it's just a show about abusing Jordan.
I like it.
But I want to really dare to say, you and your team are really pioneers in the data analytics space. So I want to pause and I want to give you an opportunity to talk about what it is that y'all are working on, because you got so many irons in the fire right now from an analytics standpoint. And I want people to understand that we're not talking about data analytics from a risk mitigation standpoint. We're talking about operational analytics, and there is a inherent difference between those. So, Jordan, let me mute myself for a few minutes, which is always a hard thing to do, and let me give you the floor to kind of talk about what it is and why you're doing these things.
No, absolutely. And I, as always, good to be on here with you, and good to have everybody on here. But I think we are at that crossroads, like you said, that was very, very predictable. It wasn't something that, snuck up on us overnight. And here we are, to what you said, as a crossroads between operations and finance, to where there are major disconnects. Everything's still siloed. And to your point, we've got more barriers. How in the world can we have the level of technology that we have today and be exponentially less efficient, less accurate than we've ever been, and more disconnected from our patients? And that is exactly where we are. And it really stems from, and we'll get into this a little bit, is where we placed the patient, the provider, and the business in between it. And I think that's the issue. Now, what exposes that and lets us navigate this is what I like to call relational data. And this is not complex. There's so much focus right now on advanced AI, advanced machine learning. And we laugh because there's a reason all of these platforms, the EHR, Cerner, McKesson, Epic, Meditech, whatever it is, there's a reason they still export to CSV and Excel. But in its most basic form, we can't get simplistic relational data. I can't tell you how many practices, how many hospitals are still running paper reports, still using highlighters, trying to make 5 or 6 elements from this report and relate it to that. And so what we've looked at is, how do we start to bridge the gap between financial data, operational data, in a close to real-time format, to where clinical decisions can be made that'll influence those. And that's really been our focus. And in the midst of that, to Sean's point, is how do you remain compliant? How do you know the rules? Because they're always going to be changing the directions. And there's financial incentive, and we can all agree to this. As Sean mentioned, ACA. Had they done their homework, they would have realized exactly, we're so far behind, but we're so far behind by design and agenda. It's not because we couldn't be standardized. There is no reason that there shouldn't be a standard data transfer format. And there's not, because every vendor needs their own and call it proprietary. And if you want to tap into it, we're going to charge you $60,000 to access it through an API or something like that. So it's funny because we say the patient's data is the patient's data, but it's the facility or the provider that's paying those dues and fees to make it the patient data. So a lot of these organizations and people have held it hostage. So
let me ask you a question real quick, because let me ask you this question real quick, because we get a lot of folks listening to the podcast. Obviously, they're coders, they're RCM specialists. Can you simply define relational data?
Sure.
Put it into lay terms.
The most simple definition of relational data is taking a data point from one source, a data point from another source. And in these instances, we'll call them files, file 1, file 2. They may be in a different format. They may be in a different column and row setup. They may be whatever it is, and taking those 2 data points and then structuring them in a way that if you manipulate one, you can see the impact on the other and vice versa, forward and backwards. That's the basic definition of relational data.
Let me, and that's such a great straightforward explanation of it. Let me ask you this question, Jordan, because you were a hospital administrator as well. And, for me, there was always a struggle, right? Because you're part of an organization, you're part of a corporation where, profitability, right, is the key to, the organization being able to achieve a lot of things, right? Bringing in new technologies, bringing on additional providers, adding ancillary services into the mix, all of those different things, right? But at what cost are we looking at profit and ignoring patient care? And I'll give you an example. I'll tie it back to an insurance company because, as much as people want to point the finger at hospitals and hospital administrators for, inflated charges, and there's no doubt hospital charges are extremely inflated, and we'll get to talking about the transparency rule in a couple of minutes. But let's talk about insurance companies, right? Because the real problem starts, in my opinion, at the insurance company. Because the highest paid CEOs work for who?
The payers, the insurance companies.
The top 7 in the last 10 years. We have seen
that issue, right? That's the issue. These guys are record profits. How in COVID, the most constrained time you've ever seen in healthcare, yet they had their largest quarters during COVID.
I mean, and we're not just talking millions. We're talking hundreds of millions of dollars in profits during 2021 while we were in the thick of a pandemic. So when I hear people from insurance companies crying, oh my gosh, we lost so much money. No, you didn't. No, you didn't, because your filings with the SEC state otherwise. And you're not going to falsify, unless you're a dingbat, you're going to falsify your quarterly statements to the SEC. Not going to happen. But here's the thing, Jordan. Again, thinking about from the perspective of a practice administrator, as a hospital administrator, what are the things from an operational data perspective that they need to be focusing on right now? And what are some of the things that are available to them that would assist in making their operations more streamlined, increasing the satisfaction of not only the staff working for them, and we could talk about things like prior auth, which is one of the biggest nightmares of all, but also balancing that with patient satisfaction.
No, and I think that's huge. And some of the things that are available, the biggest thing that comes to mind as a hospital administrator. So when I was in that space, and you start to realize really quickly is how much we do on a day-to-day basis that has no billable CPT code, yet all of these productivity models, everything we do is based on some level of a CPT code, right? And the issue is tons of things. Like you mentioned, prior auth. There's no special prior auth code for the 10 hours you spend on hold to get a prior authorization. There's so many things. So when we start talking about what tools are available, really it becomes workflow management tools that can expose where are these bottlenecks, how can we stop the redundancy. As a hospital administrator, we saw a lot of that data input at patient registration, and then they go see another doctor down the hallway and the patient's filling out the same information and the office staff is re-entering that information. We look at those redundant tasks. Those are things that through software, through programs, can be used to minimize that. Now, on the flip side, you also want something that can measure and constantly keep a pulse on where you are in those processes, to where when there is an issue that falls outside of the norm or where your baseline is, you know what's going on. So you're not waiting 6 months. I mean, denials, we'll use this, claim denials. Claim denials have always been a problem. The issue in a hospital is the department, it goes to a central billing office somewhere that's probably not even in the hospital. And the department itself, maybe the physician hears about it months and months and months later. Why do we have that gap? If that's where a lot of these models that CMS and CMMI put out, that's why they failed, is the ability to give practices and hospitals close to real-time data is key to make decisions. When the OCM first came out for oncology, the data wait was 12 to 15 months. That's horrible. You can't do anything. You're not going to be successful in any model if your first data feedback is 12 to 15 months later to make adjustments. So there's a lot of simple tools out there that are available that can help, again, stop the redundant task, and then also track how much time is being spent on non-billable tasks. And I think that's where the big disconnect is. And that's how a lot of, vendors continue to charge more and more and more. Yet we're doing that work. And this has been my frustration, to Sean's point in the beginning, when he talked about the EHRs and EMRs, is how much time that physician is spending. His work RVU used to be to spend time with the patient. Now it's to enter information, and it's not rolled up correctly. And so I think the RVU model is it really truly is a failed model for what we do today as practices. And the only way that you can look at that is time-based activity costing, to look at how much time and then equate that time and activity to what the true cost is.
Well, and I couldn't agree with you more. But you went down a road that I was hoping you would, which is physicians and physician compensation. So over the last several days, there's been a lot of conversations, and there's a lot of varying opinions based on what data sources people are looking at, right? Whether it's the Department of Labor Statistics or the Bureau of Labor Statistics. I said department, I apologize. Or whether it's actually looking at their real-time data in their operational systems. For me, very rarely do I trust government data. Why? Because the motto in the government is close enough is good enough. Well, it can't be in private practice, where you're not relying on taxpayer money to keep your business afloat. You're relying on your business acumen and the people that you hire to drive your business forward, to, recoup the dollars for the services that you're providing, to make sure that your costs aren't outpacing the remunerations that you're receiving. But one of the things that was really interesting the other day, and I'm not trying to call anybody out, but you did something really cool. And it was kind of simplistic in ways, but it was really cool. And for me, the most simplistic things oftentimes are the most profound, right? And you created this line chart, right? And you had up arrows, down arrows, some arrows that were kind of stagnant, meaning things were flatlined, if you will. And there were a couple of comments as to where people were saying, you're completely wrong on physician compensation. Physician compensation isn't decreasing, it's actually increasing according to certain statistics. And I want you to kind of talk about that for a minute.
No, absolutely. And I think when we put that out, the goal was, when I created that, was to create something so simple that people just got logic, because we hear so many different things. What's happening with physician compensation, hospital reimbursement. And so these lines were literally just linear lines with either a positive slope or a negative slope, and we assigned, a topic to it. And so assigned a negative slope to physician compensation and reimbursement over time. And that's just the facts. However, some people felt that, like you said, it should be a positive slope. Well, the issue we have with that, for those of us that are in the field, is for the past 10 years, we've watched the conversion factor continue to decrease. We've also watched commercial payers slowly creep towards that direction of Medicare reimbursement, so decreasing what they're paying. And yet some people still really wanted to say that the physician compensation has increased in a sea of, and I think you have to take this to make it apples to apples, of where physicians, not just their compensation, but what they're paying out, to your point, to maintain a practice, the cost of the EHRs that's going out, the cost of the malpractice, not to mention this really small detail called inflation, that's super small, right? I mean, this is crazy. That makes a huge difference.
What are we at, 6.8% inflation?
Yeah.
What are we at, 6.8% inflation?
I think it's somewhere around there. But to say, in the sea of all those elements and variables, if you plug those into a formula, that you're going to see a positive slope for physician compensation is erroneous. It doesn't exist. It definitely is a negative slope. I mean, we've watched physicians continue and continue. I mean, we had macro MIPS. This was a good one, right? So when we had macro MIPS, physicians were spending $20,000, $30,000, $40,000 to recoup $5,000 in practice administrator. I mean, so their compensation has definitely decreased. And it was interesting to hear people try to argue, because the majority of people, 90%, have said, absolutely, we agree with the slope of the line, but there's that 10% that's dead against it. The issue I have is generally the 10% that are against it have nothing to do with healthcare. They have no healthcare experience.
Well, you're right. And hold that thought for a minute. I want to go back. I was slightly off on the inflation rate. According to the latest report from the Bureau of Labor Statistics, the annual inflation rate in May was 8.6%, its highest level since 1981, as measured by the Consumer Price Index. Folks, in the month of May, we were at 8.6% inflation, the highest in more than 40 years.
And your difference in what I try to tell people is, this has long been surpassed, but that slight difference in what we call the GPCI, or the geographic index adjustment based on your location, or the salary wage index for a hospital, doesn't remotely come close to compensating for those differences. And especially when we get into talking about urban providers versus rural providers, that's a huge issue.
That's right. Now I want to speak again to the fact of physician compensation decreasing. And there's two aspects. Now, I will say this. We have seen a significant shift away for physicians from the hospital setting into private practice. And it's for a lot of different reasons. One, they want their autonomy back. They want to practice medicine the way that they believe is best suited to them and their patient mix, and not to have MBAs telling them how to practice medicine, who have never spent a day in a clinical course, okay, or treating a patient. Second, insurance companies. United Healthcare has been notorious for this. I have multiple letters out right now to senior vice presidents of regions around the country for United Healthcare, who have come out and said, we are reducing your fee schedule from this to this. You have 90 days in which to appeal it. I have one group that sent 27 emails to the email address that was listed, as well as made phone calls. And not one time did they receive a return call from anybody. Okay? No return emails. But what UHC has basically said is, this is a take it or leave it. And folks, if you don't believe me, there was litigation on this very issue in 2021. And I believe it carried into 2022. Now, there may have been a settlement agreement. There may have been something that happened to make the case kind of go away. But let me tell you something. People litigated it, and they had every right to do so. But here's another example as to why physician reimbursement is going down. Again, we have something called sequestration, right? That takes money away. But we have seen Medicare, well, Congress, kick the can down the road for many years, right? Because there was supposed to be a 10-year phase-in for a reduction in the physician fee schedule for Medicare. And every year, Congress has come back and has said, we're going to give it a stay of execution. We're going to hold off till next year. Well, folks, in 2023, right now, there is a proposed 4.5% reduction to the conversion factor. Right now, the conversion factor is 34.
That's just the conversion factor. So Sean's going to tell you what the conversion.
That doesn't include RVUs.
Yeah, once you include everything else, there are some projections coming out, and we've done some of these that think for certain specialties and physicians, you're talking north of between 10 and 15%, possibly, with everything else applied, sequestration.
And I agree with you. I have seen those numbers. We have run some of those models ourselves, and we're seeing what we've seen is somewhere between 10 and 12%. But again, there are certain subspecialties who have just, for whatever reason, been crucified over the last 5 to 7 years, and they're going to take an additional beating. And when you look at these stretched over a period of a decade, I mean, in some cases, we've seen north of 20% reduction. You know, I tell people all the time, the 80s Mercedes are long gone. We're lucky if our doctors could afford a 1990 Yugo. But here's the deal. A 4.5% reduction to the conversion factor in 2023 from 34.61 down to 33.08. And a lot of folks, if you're trying to figure out what is the conversion factor, that is the dollar amount that is set by Congress as to how much they're going to multiply each relative value by. Now, there's a whole algebraic equation that goes into it, right? So you have to take the work RVU multiplied by a work geographical practice cost indice. That's the GPSI that Jordan was talking about. You add that to a practice RVU multiplied by a practice GPSI, and then you take a malpractice RVU multiplied by a malpractice GPSI. You add the three of them together to get what's called a total relative value, and then you multiply that by a conversion factor. Remember, the whole point of this is that Congress needs it to be budget neutral. We used to have a budget neutrality adjuster, and that would adjust things by, like, I think it was 0.09% or somewhere in that area. And they did away with the budget neutrality adjuster, and they said, we'll find another way. Look, people talk about, oh, well, we saw an increase to the RVUs. Well, you may have seen an increase to the RVUs, but you saw a decrease either in your gypsies or in the conversion factor. And they do that because they have to maintain budget neutrality.
Yeah,
Jordan, anything you want to say about that?
No, I mean, that's spot on. I think you be careful, you know, what the left hand giveth, the right hand will take it. And I think that's the issue, is a lot of people will look at just the RVU, and we've already identified, we won't go into it, the RVU model is a blown, failed model. There are much more accurate ways, but that's what we have. That's the standard. But this decrease every year of the conversion factor is really has been problematic. And I think it's not getting better. We are in a gap right now. Normally, we always see almost to the day the MPFS proposed rule come out and the OPPS come out. If you notice, there's a gap right now. We have not seen the OPPS come out, and a lot of people and their indicators that we have think that we're going to see this increase for the hospital. So why, as Sean said, are they beating down and crucifying the MPFS and freestanding, yet they're wanting to raise the hospital? And we have payers that don't want to pay for anything in the hospital. They want it to be done at an ambulatory surgery center or a freestanding center. This sets the stage for a very problematic issue. And if you don't think it's an issue, one thing you can Google here locally, we have the case Blue Cross Blue Shield of Mississippi versus UMMC. They are at a 3-month standstill to where they can't come to an agreement. Meaning, if you have any services done and you got Blue Cross at UMMC, our largest hospital in the state of Mississippi, you are out of network, not covered. This, to me, is completely, as Sean said, it's unacceptable. It's absolutely unacceptable. And because you can't talk out of both sides of your mouth and say, we're for patient access, we're for patient care, the patient first, and then turn around and do that kind of stuff. And this all stems back to the money that we're talking about and how these conversion factors and things like that work.
So I couldn't agree more. I want to go back to something that we started talking about, and that's prior authorizations. Because to me, I believe wholeheartedly, prior authorizations are the greatest scam in healthcare. Because we spend hours on a phone trying to get a prior authorization for either a treatment with medications, a surgical intervention, a access to a CT scan or an MRI. And we get the prior authorization. Sometimes they get denied, but let's just say we get the prior authorization, but you get the notice, right? That says this prior authorization is not a guarantee of reimbursement. Well, what the heck is it?
So precisely that. We've wasted time that has no billable CPT code, but we've paid staff for only to get an authorization, which isn't going to be paid. I mean, it's the most mind-blowing thing ever. And as we're seeing more and more people elect out of Medicare and go to Medicare Advantage, the problem is only it's being exacerbated tenfold.
So there are states right now that Texas is one of them. Texas has put into place something called a gold card. And basically, it's something to the effect of if you achieve 95% prior authorization on CPT codes. For those CPT codes, once you achieve that percentile, that 95%, you no longer have to get prior authorizations. That's a huge, huge benefit to medical practices, right?
Oh, it's a huge benefit to medical practices. I mean, number one, it gets the patient to care faster. It also decreases the amount of money that's being paid for staff. It's actually optimizing the practices and the physician, their resources, by not having to fight an unnecessary battle. I mean, day in and day out, we deal with people that are like, well, we only have a 29% first time, denial rate for the first. I'm like, why are we even having this issue? Like literally for a lot of treatments, we follow the same pathway for every patient. It doesn't deviate. And if you're within those confines of what you're talking about, Sean, well, why are we still having to jump through hoops? I mean, if this is standard, why does it take the legal case on the backside to go fight it, or a patient died waiting for care? Why does it take that when we were going to follow the same pathway? That's the frustration. And it's an algorithm, right? All these payer and insurance companies,
that's right.
You can auth the same thing, same patient 10 times, and 3 of them are going to deny, and it's just based on the algorithm that they have. But the gold card's huge. I think it's great. We don't want to see the gold card, though, end up on a post-treatment adjudication to where then you get held up on the backside, because then we've got the same problem. So we really want it end to end, and we've been able to give some pretty good input in the Texas area for the gold card.
And we're actually starting to see Tennessee move in that direction. Now, I hope there's other states, and if our listeners, our viewers, if you want to share with us in your state, if you're seeing something like that, the gold card, as is in the state of Texas, let us know. We'd love to know what states are moving in that direction. The last thing, Jordan, I want to talk about, because I know you and I both have some significant thoughts on this. Private equity in healthcare. So Yeah, you started to talk about it just a couple of minutes ago. And I told you, hang on, because we're going to get to it. But private equity. Look, everybody believes that healthcare is a golden goose for whatever reason. I don't understand it. But, well, I do, because it's $1 trillion industry and everybody wants a piece of that pie, right? But it's like I tell people all the time. If you're an attorney that's been practicing a state law for the last 10 years, and now all of a sudden you think you're going to represent somebody in a False Claims Act case, guess again. It ain't going to happen. You're going to be in big trouble, and so is your client. And I could say that because this is what I do for a living. I work with 30 law firms across the country on FCA cases and healthcare fraud statute cases and stuff of that nature. But with private equity, venture capital, VC, mezzanine financing, whatever terms you want to use, what are you seeing as the biggest challenges and the biggest issues with physicians partnering with these individuals coming from other industries, not understanding the world of healthcare to the degree that people who have ate it, slept it, breathed it, bled it, are seeing?
No, I mean, I think it's, I have nothing against it when it's for the right reasons, but we've been on this 5 to 10 year high of it being for the wrong reasons. And, these companies as a position are looking for what we call, portfolio diversification, right? So they don't need every investment to hit. They need 1 or 2 out of 10 to hit big, and the other ones just serve as a loss. The biggest example we give in healthcare, and it'll still kind of go down in history, obviously perverse reasons for the Theranos and their failure, but Warren Buffett and the Haven, all these people, chunking money at a lot of things, the problem will be solved. Healthcare is absolutely different. But what people had figured out was if I can throw enough money in the short term, we can make a lot of money. But it leaves the healthcare system in shambles because it drives the cost of healthcare up. We talk about this redundant waste, and health tech is one of the biggest ones. And I work in health tech. It's one of the biggest ones, these kind of smokescreen solutions for physicians and things like that end up not delivering because all they need is the sale for an evaluation so they can make a quick exit. Now, on the flip side, for physicians and providers, these guys come out looking like the white horse and the saving grace to help them, extend their runway of their practice and things like that. And then they end up and they go that route and it doesn't work out for them. We see this right now. I was at a conference several weeks ago. The explosion in people opening infusion centers right now. I mean, it's an explosion. Outpatient infusion, and private equity has rushed to it. VC has rushed to it to tell these people, hey, we'll fund it. We'll do it. And you only have to give up, and then it's a huge chunk of what you have to give up. And so I think that's the problem because it's not sustainable. The agendas behind private equity and VC have to change in healthcare to not being about the 2 to 4 year window. We've got to, if we're going to fix this problem in healthcare, the agendas better start being 8, 9, 10, 15, 20 years out. It's the only way it's going to get fixed. But up until this point, it's all been about kind of a quick turn. And to your point, I mean, just chunking money at this it's failed literally every time it's happened.
Yeah. And for me, look, nothing against venture capitalists, nothing against private equity. They're trying to make money. I get it. And they're looking for industries where they're going to get a huge ROI on their investments. But physicians need to recognize if you're going to partner with one of these companies or you're going to sell a portion of your organization to a private equity group, you are back in the same situation if you left the hospital that you were in with the hospital because you're going to lose some of that autonomy. You're going to have KPIs. You're going to have metrics. You're going to have to do things in line with what your investors believe is the right way to conduct your business.
The
And if
primary
you don't want to play that way, go ahead.
No, the primary answer when you get in bed into that situation is to the shareholders first, not the patient, not to how you want to practice. It's to the shareholder.
Well, it become and now you become nothing more than an insurance company who is beholden to its shareholders. And I love physicians. I've been a physician advocate now for almost 3 decades. Okay. But physicians as a collective group tend to make a lot of bad business decisions. Or they put individuals. This is one of the only industries that I've ever seen in my life where people matriculate from the person who answered the phone to CEO of the practice. And unfortunately, most of them don't have the requisite skills needed to be able to hold that CEO position. I'm not saying they're not intelligent people. They are. They're intelligent people. But they had very specific capabilities, right? Look, I'm not saying somebody who answers the phone today, 10 years from now, couldn't become CEO of an organization and do a heck of a job. They could. But you got to give them the tools. You got to give them the education. You got to give them the pathway forward. Otherwise, it's just, well, Sean was answering phones and he does a great job and people really seem to like him. And, Jordan was our senior auditor and he's not here because he wanted a $5 an hour raise and I couldn't afford it. So we went somewhere else. So, hey, Sean, why don't you become our senior auditor of our group now? Okay, well, what does that mean? Just look at medical records and here's a CPT book and an ICD-10 book and, here's some classes that you can go to on, how to code an E&M service. People think I'm joking when I say this, and I'm not. I spend so much time in courtrooms. I spend so much time in hearings. I spend so much time in peer reviews. I spend a ton of time on site at client locations. And I sit down and I talk to the practice administrator and I say, help me understand how you got to be the practice administrator. Well, I was the coder. And, we collected a lot of money and we did really well. And, our office manager left and, we always like to promote from within. And the doctor thought, hey, you're really good at this coding job. And I think you could do the office manager job.
So many times and so many people get enamored by the position or the title. And then there's people like, myself, people like you, like we know what our limitations are. I will be quick to tell you, yeah, I don't have that. I can't do that. I possibly know somebody who can, but a lot of people will get in those roles. And I think as an industry, we've belittled and bastardized the value of understanding things in context and understanding the historical, the amount of time it truly takes to become an expert. People take a weekend course now and they're an expert. And again, these are the people we end up in court with.
Yep. Yeah, I've seen it. I'll finish out with this quick little story. Jordan, Eric, myself, Ryan Vaughn, our team of auditors at Doctors Management, we were asked to engage in a case where an individual was retained by the opposing counsel. And for the same work that we were able to complete in 6 hours at probably $10,000 for that work for our whole group, this other organization spent in excess of, I think they said 500 hours to the tune of, $300,000. And when we saw the final product, it was the most egregious, worthless piece of junk I think we've ever seen. Remember that case?
Oh, absolutely. And it's frustrating, right? Because they get sold on this expertise. They get sold on and they don't know. So many people don't know to ask a question, don't know to ask a second opinion. And that's the bloat of healthcare and the stuff we do, of the excess expenditures that aren't necessary.
Absolutely. So Jordan, in closing, can you share with our viewers, our listeners, what all you have coming down the pike from a technology standpoint?
So no, absolutely. I mean, some of the things that we're working on is integrated coding systems. So again, not automated, but integrated, augmented to be able to check at a high level what patterns and trends are. And this is from systems that are actually billing. So not what you coded and captured in, but actually what's going out the door. So that's an arm. Prior authorization. People love to say, hey, this is a completely automated solution. Listen, guys, that doesn't exist. I understand EDI 278s back and forth. I understand how they work, and I understand how and why the payers don't want them to work. And just use some logic. Do you think that the payer wants, an insurance company wants automatic authorization no, the answer is no, absolutely they don't. So we've looked at and we've created an ecosystem, one of our solutions that we look at in prior authorization that's able to integrate it, but bring all the data from health policies to price transparency to policy checks and all this stuff in one place. So you're maximizing your time and not going here and there to look for everything. So that's been one. I briefly touched on price transparency, which Sean and I've had a focus on, but ingesting all of this data, which to Sean's point, you would think, do you really want to solve healthcare's problems? And the answer is these hospitals can't upload a Excel file that's 5 columns. That's all they ask for. So can we really solve
mind-boggling?
And so, we focused on ingesting that data, making it relational, but then partnering and using this software in group, in large groups and small groups, and then aligning the subject matter experts. I can't say that enough. The technology of these, and we'll hit on them again, PE and VC companies that are purebred tech. And it's great. It may look good on a spreadsheet and look like it has all the bells and whistles, but when you look under the hood, there's a lot of things missing that only a subject matter expert is going to be able to catch. That's it. And so, but for them, it's for Sean and I, it's really been about consistency, and Eric and the rest of the guys, it's been about consistency over time and delivering. These businesses only need to deliver one time. They only need to sell. They don't need to deliver. They just need to sell. And there's a big difference. And I think that's where I come in. Sean comes in. A bunch of us collectively have gotten together to try to break that mold and tell people, listen, we'll even go at risk with you. The big guys aren't going to go at risk with you. We'll go at risk with you just to show you it can actually do it. So that's some of the stuff we've worked on.
Awesome. And I know, look, I follow you on LinkedIn, even though I get a chance to talk to you, a few times a week. I still follow you on LinkedIn because I feel like what you put in writing is so much more intelligent than what I hear coming out of you on a telephone.
I like it. That's what I tell people. Yeah, just pay attention to what you're writing.
I love you. I love you, man, and it's all in good fun. But seriously, for our listeners, if you're not following Jordan Johnson on LinkedIn or on other social media outlets, you're missing out on a tremendous opportunity to learn from somebody who is a true disruptor in the industry, somebody who is a master of his craft, and somebody who is always willing and available and ready to be able to answer questions, to the complex questions, in a way that is digestible, easy to disseminate, and user-friendly. So make sure you hook up with my buddy, my good friend, Jordan Johnson, my fellow Chucklehead, who I'll be seeing a little bit later on our Coffee Compliance and Chuckleheads Compliance After Dark with our other little buddy, Eric Rubenstein. Folks, thanks so much for, again, tuning in, logging on, and just hanging out with myself and my special guest, Jordan Johnson, today on The Compliance Guy. Again, thank you for making us a top 25. We're actually number 6 out of thousands of podcasts out there on FeedSpot, which is an independent blog on podcasts, largest collector of information in the podcast world. We are number 6, thanks to all of you. And also, thank you so much for the thousands of nominations that the Compliance Guy podcast actually received for the People's Choice Awards. If you feel so inclined, you can go to greatpodcastawards.com, register, and you will find the compliance guy in 2 categories. First is the Andy Curry Award, and the second is in the business category. So if you're up for it, please vote. You can also follow us on Anchor, Apple, Spotify, or your favorite podcast platform. And until tomorrow, remember, be good to yourself, but more importantly, be good to each other. Y'all take care.